Good day, class. Let's begin our discussion on therapy, chapter 15. Chapter overview. Therapy refers to how mental disorders are treated with the help of the knowledge base of psychology. Topics to help you feel better: psychotherapy, the talk therapies including psychoanalytic, humanistic, behavior, cognitive, group, and family psychotherapy. Issues in psychotherapy, including culture, values, and the evaluation of psychotherapy effectiveness. Biomedical therapies such as drugs, brain stimulation, surgery, and lifestyle changes. And prevention of psychological disorders, building resilience. The psychological therapies, changing psychotherapy methods. Improving treatments of mental illness, from throwing away the key to finding the key. Psychoanalytic and psychodynamic therapy, bringing the unconscious into awareness. Humanistic therapy, nurturing positive growth. Behavior therapies, changing associations via exposure therapy or using consequences. Cognitive therapies, changing unhelpful beliefs and interpretations. Group therapy, mutual support, and family therapy, changing the interactions. In the first few pages of this chapter, what mental health problems did Kay Jamison have? What benefits did her therapist provide? He saw me through madness and despair. He was very tough, very kind. He understood more than anyone else. He taught me my mind and brain. Psychotherapy heals. Kay Jamison suffered from bipolar disorder and periods of depression and mania. The quotes may reveal the therapist's commitment, concern, understanding, and tough confrontation when needed helped her in becoming and staying mentally healthy. Missing from the quotation is a sense of the goals for therapy, although the author's weekly therapy for years was not likely to follow today's norm of time-limited, problem-focused, goal-oriented treatment. The history of mental health treatment. When people have displayed unusual behaviors rooted in the mind, these people have often been locked away or treated using old ideas of mental illness. Old ways of getting rid of the evil spirits include beating them out of people, bleeding them out of people, or letting the spirits out through holes drilled in the skull. Now, what we have here, this chair was designed to be an improvement in medical treatment. It was meant to have a calming effect on people with mania. This chair was designed by Benjamin Rush. He was a strong advocate for more humane treatment of the mentally ill. And of course, it would be much more comfortable than trifenation, where people have holes drilled into their head. Some people with autism find firm restraint to be dramatically soothing when they are overwhelmed by stress. So there is some support for some of these ideas. Other reforms in treatment include seeing the insane as ill instead of being possessed, treating them with tenderness, not harshness, housing them in hospitals rather than locking them up in asylums, developing psychotherapeutic treatments, medications, and community supports to allow life outside of hospitals. Current forms of therapy. We have psychotherapy, an interactive experience with a trained professional working on understanding and changing behavior, thinking, relationships, and emotions. Biomedical therapy, the use of medications and other procedures acting directly on the body to reduce the symptoms of mental disorders. Combining therapies. There are various forms of psychotherapy. An eclectic approach uses techniques from various forms of therapy to fit the client's problems, strengths, and preferences. Medications in psychotherapy can be used together and may help each other achieve better reduction in symptoms. Here are some influential schools of psychotherapy: psychoanalysis, psychodynamic therapy, humanistic client-centered therapy, behavior therapy using conditioning, and cognitive therapy changing one's thoughts. For psychoanalysis, we have Sigmund Freud's legacy being carried on today. For humanistic, we have Carl Rogers and Abraham Maslow. For behavior therapy, we can look back to B.F. Skinner and Ivan Pavlov applied to people. And for cognitive therapy, Aaron Beck and Albert Ellis, reducing errors and distress. So let's look at psychoanalysis. The goal of psychoanalysis to release the tension of repression and resolving unconscious inner conflicts. Sigmund Freud believed that many people have anxiety related to id, ego, superego conflicts, such as repression of sexual wishes. The techniques of psychoanalysis are such as free association. The patient speaks freely about memories, dreams, feelings. Interpretation. The therapist suggests unconscious meanings and underlying wishes to help the client gain insight and release tension. These psychoanalytic conflicts were presumed to exist among the id, ego, and superego. These are parts of the personality often assumed to be related to sexual desires that are repressed because they feel inappropriate. You should note that as this picture shows, Freud would normally sit out of his patient's view so that they would be more uninhibited in their associations, less likely to be distracted by him, and more likely to transfer onto the therapist the feelings associated with past people. The interpretation and psychoanalysis. The therapist may see unconscious meaning in the client's resistance, dreams, and transference. Resistance. Resistance is the therapist notices times when the patient seems blocked in speaking about certain subjects. They will simply try to avoid them, for example. And dreams. There may be themes or latent content behind the plot of a patient's dream. The idea is that the dream itself may be somewhat mundane, but if you look beyond the manifest content and look at the latent content of the dream, maybe there you can see the themes that really matter, themes that may help the patient to uncover their issues. And then there's transference. The patient may have reactions toward the therapist that are actually based on feelings towards someone from their past. Psychodynamic therapy, derived from the psychoanalytic tradition, but compared to psychoanalysis, there are fewer sessions per week and fewer years, less theory about sex, id, and superego. The client now faces the therapist and focuses on the present, not just the past. Therapists help reveal and resolve the dynamics, the forces and changes in the individual. The focus is on improved self-awareness and insight into unconscious thoughts and feelings which may be rooted in past relationships. In addition to insight, therapists suggest changes in patterns of thinking and relating to others. For example, the man who could not feel love because he felt it was not manly, he could resolve this tension and risk feeling love. The humanistic therapies. Humanistic psychology, led by Abraham Maslow and Carl Rogers, emphasizes the human potential for growth, self-actualization, and personal fulfillment. Humanistic therapy attempts to support personal growth by helping people gain self-awareness and self-acceptance. Client-centered therapy is Carl Rogers' name for his style of humanistic therapy. Humanistic versus psychoanalytic therapy. Both therapies seek and promote insight. So, the goal for humanistic psychotherapy, promote growth. For psychoanalytic, cure mental illness. How to improve. Take responsibility for feelings and actions and accept oneself. Humanistic. For psychoanalytic, bring unconscious conflicts into conscious awareness. The role of the therapist. And humanistic, provide an environment in which growth can occur. For psychoanalytic, provide interpretations, for example, of dreams and resistance and transference. Content of therapy. For the humanistic psychotherapy, conscious feelings, actual self, and ideal self. Whereas for the psychoanalytic perspective, looking at unconscious conflicts being the content of therapy. And the focus of time. In humanistic psychotherapy, the focus of time is on the present and the future. For psychoanalytic therapy, the focus is on the past. The style of the client-centered therapist. Being non-directive, being genuine, being accepting and showing unconditional positive regard, and being empathetic. So, being non-directive. Let insight and goals come from the client rather than dictating interpretations. Being genuine. Be yourself and be truthful. Don't put on a therapist's facade. Being accepting and showing unconditional positive regard. Help the client learn to accept themselves despite any weaknesses. Being empathetic. Demonstrate careful attention to the client's feelings, partly by reflecting what you hear the client saying. Showing empathy through active listening. Client-centered therapists show that they are tuning in to clients' feelings and meanings. 1. They summarize and paraphrase. So what, your father wasn't around much? 2. Invite clarification and elaboration. When you say anxiety, what does that feel like to you? What is going on in your body and thoughts? And 3. Reflect feelings. It seems like you are disappointed. Am I right? So by using active listening, people are able to truly communicate with each other. The person who's listening is doing so actively by paraphrasing and summarizing what they've just been told so they can confirm if the person who made the statement says, yes, that's what I was trying to say. You also invite for clarification and elaboration. If you didn't get it right, you ask for clarification and ask for clarifying items or statements so you can get it right, so you understand what they're saying. And then reflect feelings. You want to be able to reflect back to them what you think you are hearing them say and to confirm it. You're not putting feelings onto people. You're asking to confirm what they actually are feeling. Behavior therapy. Sometimes insight is not helpful to recover from some mental health problems. The client might know the right changes to make, but finds that it is hard to change actual behavior. Behavior therapy uses the principles of learning, especially classical and operant conditioning, to help reduce unwanted responses / unwanted behaviors. These might include behaviors such as addictions or emotions such as panic. So even though it's not always correct and beneficial for you to have insight about something in particular, you need to also understand that simply shaping the behavior or response is not always going to be enough too. So you have to also look at other things too by looking at the origin of some sort of behaviors that may be problematic for a particular individual. Classical conditioning techniques. We have counter conditioning, refers to linking new positive responses to previously aversive stimuli. If you've been conditioned to fear stores because you have had panic attacks there, you could be led into a store and then helped with relaxation exercises. The goal is to associate stores with relaxation, a state incompatible with fear. Exposure therapy. A conditioned fear can worsen when avoidance of the feared situation gets reinforced by a quick reduction in anxiety. Guided exposure to the feared situation can reverse this reinforcement by waiting for anxiety to subside during the exposure. The person can habituate to, that is, get used to, the anxiety itself and then to the feared situation. What mistake is Professor Gallagher making here? Hint: systematic desensitization might have been more effective, though less dramatic. Now, versions of exposure therapy. Sometimes exposure to the feared situation is too anxiety provoking or impractical. In those cases, you can use systematic desensitization. Beginning with a tiny reminder of the feared situation, keep increasing the exposure intensity as the person learns to tolerate the previous level. So you keep adding more and more of that feared item as the person gets used to it increasingly. And then there's virtual reality therapy. This involves exposure to simulations such as flying or snakes. Aversive conditioning. When a person has been conditioned to have a positive association with a drug, they like the experience of being high, for example. This is what can be done. So you have, using the ideas of classical conditioning, you have the drug causing some sort of nausea here. All right, so we can provide you with a certain drug that makes you nauseated. So aversive conditioning, you can start to associate the drug with a negative response. So you have the drug you really like, which is the alcohol in this example. It is a neutral stimulus. The neutral stimulus means that it does not, in its current state, cause you to become sick to the stomach. So what they do, they have the neutral stimulus of the alcohol, and then they add the drug, like antabuse. So when you drink the alcohol now, that's now containing the drug antabuse, you begin to associate the antabuse with the drug, or more properly, begin to associate the drug, the alcohol here, with the feelings of being nauseated. After you've paired it enough together, you have now transformed that neutral stimulus to nausea, the alcohol, into a conditioned stimulus for nausea, the alcohol now brings about nauseated feelings. So what you've done is you've replaced the potential positive vibe and feeling you get from consuming alcohol with something that you do not like, something that makes you nauseous. Operant conditioning therapy. Operant conditioning, the shaping of chosen behavior in response to the consequences of the behavior. We look at behavior modification. It refers to shaping a client's chosen behavior by making sure that desired behaviors are rewarded and problematic behaviors are unrewarded or punished. Here are some applications of operant conditioning. We have applied behavioral analysis application. This is used with nonverbal children with autism. It rewards behaviors such as sitting with someone or making eye contact, and sometimes punishes self-harming behaviors. Or a token economy. It uses coins, stars, or other indirect rewards as tokens that can be collected and traded later for real rewards or preferred rewards. Critiques of behavior therapy. Does it work? And when it does, do the changes stick without insights and other changes to hold the new behavior in place? It does often work, but extinguished behaviors and reactions do spontaneously appear. To ensure maintenance of changes, a transition is needed from artificial rewards to awareness of natural and environmental consequences. Is it ethical? Since conditioning operates below conscious awareness, couldn't people's choices and reactions be manipulated without their consent? To minimize ethical problems, we acquire consent at least of guardians, and we develop goals for treatment that are more humane than the alternative. For example, shaping autistic behavior is seemingly better than institutionalization.